Good morning, everyone. I'll be talking about the microsecond pan-retinal photocoagulation in diabetic retinopathy. These are my financial disclosure. As we have been using conventional laser for pan-retinal photocoagulation for more than 3 decades, and we have experienced the complications which happen because of this laser. As you can see on this picture, the large scars in the periphery, which leads to visual field loss, as well as many a times we have experienced increase in the fibrovascular traction in these patients, which can lead to retinal detachment. Along with that, there is a possibility of inadvertent laser to the macula, which can lead to vision loss. These patients, when they undergo conventional laser, they do experience a lot of pain, and many a times it is not possible even to complete the laser session. Then came the pattern scanning laser, that is Pascal. Pascal reduced the pulse duration to almost 30 milliseconds, which made this laser much faster as well as less painful to the patient. However, the efficiency of Pascal in comparison to conventional laser has shown that its efficacy is not up to the mark compared to the conventional laser in patients with proliferative diabetic retinopathy. Micropulse laser has been around for almost 2 decades. Micropulse laser, as we can see in this picture, is the laser where we have short pulses of the laser, which eventually reduces the temperature as we experience in conventional laser at the laser spot. Eventually, it leads to lesser tissue damage but with the same therapeutic effect. And micropulse laser has been used in many diseases, including diabetic macular edema, central serous chorioretinopathy, and the therapeutic effect has been very encouraging. So today's question is, can microsecond PRP be considered for pan-retinal photocoagulation in proliferative diabetic retinopathy management to further reduce the side effects while maintaining the therapeutic effect? We use navigated microsecond pulsing laser for this particular study because of its true confluency and documentation. We need a perfect documentation when we are talking about a sub-threshold or a microsecond laser where we want to split the treatment sessions, and it allows us for the complete documentation, and with the help of Nevilas, the speed of the photocoagulation using microsecond is also very fast compared to other laser systems. As we can see in this video, where the laser is being done on the computer screen, this is primarily a fundus-based camera where you really do not need to see through the slit lamp as we do in conventional laser, and you can see that the physician as well as patient is very comfortable, and the laser is being done using eye tracking of the system. We included patients who had very severe NPDR or early PDR, which are not eligible for any conventional pan-retinal photocoagulation according to the ETDRS study. That's why we excluded patients who had high-risk PDR. We included both eyes of the patient, given the both eyes had a symmetrical disease of the same stage of the diabetic retinopathy, because we wanted to randomize these eyes into a microsecond laser and the other one for the conventional laser. So we have the same subject as control. Patients were followed up at month 3, month 6, and month 9. They underwent color fundus photography, infrared images, autofluorescence images, Humphrey's visual field 30-2, and flash ERG was performed at baseline and month 9. There was a rescue pattern scanning laser PRP if the progression of the proliferative diabetic retinopathy was noted in presence of any new vitreous hemorrhage or development of any new neovascular complexes. These patients underwent a rescue laser. These were the parameters which were done for the two groups. As you can see, the Nevilas laser, we used 577 laser, 15% duty cycle. The conventional laser was 532 nanometer, and we used a 30 millisecond pulse duration. What were the outcome measures? Primary outcome measure was difference in disease progression between the two groups. Secondary outcome measures were visual acuity, contrast visual acuity, retinal sensitivity, on HVF 30-2 and ERG parameters. These are the results. As you can see that there was no significant difference between the baseline and month 9 in both the groups. However, when we compared between the groups, there was no difference between the groups as well. That means Nebulas microsecond did as good as a pattern scanning laser. However, one eye in the microsecond group progressed to have vitreous hemorrhage at month 6, which eventually required a rescue laser. This is one of the case examples from this study where you can see the right eye had undergone a microsecond PRP using Nebulas and the left eye underwent a conventional laser. As you can see that the right eye is showing no scarring anywhere in the retina. The left eye has laser scars, as you can see on this fundus picture. This is one of my patients from my clinic where I did both eyes microsecond laser, and this lady came for a regular follow-up, and you can see that at 2 years of follow-up, we can hardly see any scarring in this patient, and there is no progression of her early PDR during the 2 years of follow-up. We used Nebulas laser, and now the Nebulas laser has a pre-planned PRP, as you can see in this video, where the PRP has already been planned, and now the physician is just doing the laser in the pre-planned area, and you can see that the area being covered is very clear, and with the help of eye tracking you can be sure that this laser is done at the pre-planned locations. With this, I will conclude that our prospective pilot study proposes that microsecond PRP could be an alternative to conventional PRP to avoid complications which are associated with conventional laser. Prospective study with larger sample size with longer follow-up is warranted to establish role of microsecond laser for pan-retinal photocoagulation. We really appreciated using Nebulas for this particular study because Nebulas provides a pre-planning, documentation, and eye tracking, which is a very valuable tool to standardize the treatment with this invisible endpoint and subthreshold laser systems. I would like to acknowledge LV Prasad Eye Institute, Hyderabad, India, where I performed this study. This was my previous workplace. Thank you very much for your attention.